Hello, good morning, doctor. Welcome back to the Game Changer session by Dr. Sasi. Today, we'll see most important subjects. Why? Because these are subjects which looks very small, but they play a major role in your examination. Because in these subjects, you need to read just few topics, but if you read those few topics only, you will get questions from it for sure. Okay, so we read less, but we score more. That is the main agenda of today's session. Fine. If you missed other sessions, that I'll be forgiving you. But if you miss this session till the end, then it will be your game changer. So don't miss it to change your game in a right manner. Okay, that is the thing, and that is the motto we today will be carrying. Without wasting time, we'll move ahead with this hard subjects, but it is high yielding because from pediatrics there will be 15 to 80 number of questions, and it can go with integration with pathology, pharmacology, and on biochemistry with around 20 questions even in some cases. Fine. Yeah. Okay, guys, it's good to go. We'll move ahead with this pediatrics part. And this pediatrics part, as I told you, there will be the minimum number of questions. It will be 15 to 18, and it can even go up to 20 if it is integrated with pathology, pharmacology, and your biochemistry part. Fine. First, we'll start with this resuscitation part. If you see about this resuscitation part, you need to know this resuscitation. Mainly, here they will ask you about this two things. One is when you will start this compression, and when you will do this ventilative correction steps, and when you will do this intubation. Okay. For that, you need to know like how we progress. For example, when a baby is delivered, either mostly in a case of vaginal delivery and also in a case of cesarean section. Usually, this vaginal delivery babies, they will be more vigorous in nature, means they will cry by of their own, whereas we need less stimulation in such cases. Whereas mostly in a case of cesarean section, we need to do stimulation, and after once just get back, well, then the baby will start crying. Okay, this is the usual scenario, and in this cases, first we'll start with this first. First, what we will do? First, we will set up a team in a case of usual things. We'll receive the baby and we'll check whether that baby is a term baby or the baby's tone is good and the baby is crying. Okay, if all these criteria meet, okay, fine, then everything is fine. Then put him in the warmer, because the baby will be warm inside his mother's uterus. Whereas when you come inside, it feels that baby is hypothermic, means the environment is very much cold. So to prevent this hypothermia, what we'll keep them under this radiant warmer. First, we'll keep them under the radiant warmer. Fine. Then we'll position the airway and we'll clear off any of these fluids inside. Okay. And you should know the sequence of suctioning. The sequence of suctioning is what? It is the mouth followed by the nose. It is the mouth followed by nose suctioning. Okay. Okay. Once you check it, then you just warm the baby with what? With this radiant warmer. Then you just clean the baby and you just clean for any secretions. Then you stimulate the baby. How will you stimulate? You just rub its palms or rub its back. Then the baby will start crying. Okay. This is the usual and normal scenario. Once the baby starts crying, you just check for any gross anomalies. Then you just move ahead with this pediatric part. Fine. This is the usual things. But if all of these things is not there, okay, if you see this, all of these points is not there. For example, if the baby, once you stimulate also, the baby is not crying. Okay, in such cases, what you will do, you will check for the next thing, which is whether the baby is having apnea or the baby is gasping. Okay, baby is having apnea or baby is gasping. Then you will check for this heart rate of the baby. Then you will check for the heart rate of the baby. Usually it should be more than 100. Then you consider, yeah, if it is more than 100, right, then no problem. Okay, but if it is less than 100, okay, it is normal one. But if it is less than 100, then what you will do, you will just go for this positive pressure ventilation. So usually we'll be having this small amber bag which will be having the capacity of 250. Then you will start with this positive pressure ventilation. Then you will go for this, I'll attach the monitor for SpO2, whether the SpO2 is maintaining or not. Then you can even consider about the ECG part. Then you just do it for 15 seconds. Once you give oxygen and positive pressure ventilations, you just give for the 15 seconds, and after that you check again. You check for this heart rate again. If the heart rate is still less than 100, then you should do for this ventilation correction steps. For this ventilation correction steps you should do. For example, you need to check how you are holding the baby, whether you are holding, while ventilating the child, the mouth is open or not. You can use the C and E techniques to open its mouth, and once ventilating, you should see whether the baby's chest is rising or not. Means then only it is an adequate and proper ventilation. If not, you are just ventilated to the outside, it won't reach the baby. So first you will do, if again the heart rate is less than 100, first you will do, it is what it is, this ventilation correction steps. You will check for this ventilation correction test, you will check for this movements. So once you check all these things, then you can try for ETT, okay? You can try for ETT at this moment, but it is not definitive one. You just do for this ventilation correction steps. Once if ventilation correction steps you did, like you opened the mouth adequately, you made this extension and you just made this see like whether there is a proper rising of chest. So everything is well, then you check for the heart rate again. If it is still, if it is more than 60, if it is more than 60, you proceed ahead, then you will go for this routine usual management. If it is not, okay, then if you see, if the heart rate is still 60, okay, if the heart rate is still 60 or if it is less than 60, then you need to go for the next step. Then it is the definitive management of ARV, which is this ET tube. See, remember, first you need to give, it is this endotracheal intubation. First you need to do intubation, then you go for this chest compression, okay. Without intubating it, you cannot go for the chest compression, remember, fine. First what you will do, you will intubate if it is not done previously. Then once you intubate with this, then you will provide this 100% PPV. So once you intubate this, then you will check for the compressions. You will check for the compressions and you will start compressions. Once you will start compressions, usually you will start these compressions after less than 60. Okay, if it is less than 100, you can consider for ET intubation. Whereas if it is less than 60 only, you will start for compressions. Once you will start for this compression, then what will happen is that the heart rate will start improving. The heart rate will start improving. So they will ask you, what is there? How you will see, or how you will say that ventilation or this resuscitation you are doing is working for the baby. So it will tell like the ventilation or this resuscitation you are doing, it will be working once the heart rate is improving. So here the main parameter you will check for this resuscitation, it is what it is, this heart rate. It is the heart rate, okay, heart rate. Then what means, then then after this intubation, after you are doing this compression, means I will tell you about this compressions in much in depth, okay. And after this also, if this baby is still, if the baby is still having the heart rate of less than 60, then you should consider the other points. Like for example, you can give this adrenaline, which is this epinephrine, you can give, okay, you can give, and you should rule out for this other conditions as well. So means first you will provide warmth to the baby, okay, then you will provide this routine care, then you will check for the heart rate. If the heart rate is less than 100, then you will go ahead and you will do this ventilation correction steps, and before the means like after giving this oxygen. So once you will give this positive pressure ventilation, if the baby heart rate is still remain less than 100, then you will go for this ventilation correction steps, and after this ventilation correction steps also, if it is less, then you will go for this positive pressure ventilation like ET tube. Then if it is heart rate is less than 60, then you will go for this compressions. Then you will go for this compressions. But remember, before going for this compression, make sure you did endotracheal intubation. Okay, this is the thing. And for compressions in the infant, see, we are this big, but if you see this child, it will be very small. So for child, we can use different methods. For example, you hold this back of this child like this, and what you can do, you can put this thumb in the center. You can put this thumb in the center, and you can give compression. So this will give you the enough support. If not, you can use this 2 finger and you can do compression, but this is that it won't give much support to you. Whereas this is known as thumb encircling technique. It will give more support than this 2 fingers technique. Okay, this is how we'll do. Fine, this is the mota you need to know. So first, as I told you, warm, dry and stimulate. Yeah, compression site, like it will be like around this xyphisternum. You just go little bit above around this xyphisternum, especially on this left side. You will do compress. Or else if you are doing the thumb encircling techniques, it will be around the point of the same. It will come around here. Okay, that is the point. Yeah, fine. Then as I told you, if the heart rate you will check, means then after, means first you will check for this breathing, then you will check for the heart rate, and after that you will do this ventilation correction steps. You will adjust the mask, you will reposition the airway, you will suction. First you will suction the mouth, followed by this followed by the nose, then you will go for this positive pressure ventilation, or followed by this endotracheal intubation. Once if the heart rate is still less than 60, if the heart rate is still less than 60, we will go for this compression, okay, and the compression ratio is 1:3, okay, it is 1:3. See, you are talking about adults, like, see, first when we are talking, you just imagine, just initially just try to understand the concept and we roam around to this resuscitation part of neonates. Once we are done, we can have a multiple things, because while solving a question, you should have multiple axes, but you should know for what the reason you are solving. For example, if the child is given for neonatal resuscitation, they are not even talking about adult resuscitation, means you will get confused. Okay, so don't make things which is confusing you. So just see what is necessary points, see, understand the question, then see the options, like what they are going to ask. For example, they described about resuscitation and they can ask you about the mask, they can ask you about the ET tube. Then if you still, means it is going to good like that, it is better to go like this, because you will be having less confusions and you will be saving your huge time. Okay, so if you see, good guys, for adults it is 30:2, fine. Whereas if you see about this infants, it is the 1:3 ratio, 1:3 ratio. So just remember these things, and as I told you, this is how we'll keep this mask, and we'll use two techniques. One is known as C techniques, another one is known as E technique, remember. Okay, and this is how this thumb encircling techniques by which we'll do compression. Okay, we'll do compression, just remember, and make sure you stop your compressions once the heart rate is returned to this more than 60. Okay, more than 60, then you can do reassessment about what is the reason for it, and still you should supply what, oxygen. And once if the heart rate is more than 100, means there is a, you check for the necessity of this positive pressure ventilation. If there is no necessity, you can remove, or you can remove this endotracheal tubes. Okay, this is the main thing. Yeah, it was this, it was asked in July. Yeah, and they will ask you, like in a case of child, they ask you, like if it is present in 1 rescuer, 2 rescuer. Okay, in a case of 1, then we'll go for this usual. If it is 2 is there only in children, it is not in adults, only in children, then we'll go for this 15. Okay, so don't get confused, guys. 15:2. Okay, don't get confused. Okay, that's what. Whereas here it is 1:3. Okay, 1:3. 1 breath and 3 compressions. 1 breath and 3 compressions. Okay, 1 breath and 3 compression, that is for neonatal resuscitation. Whereas in children it is 30:2, and if it is 1 rescuer, and if it is 2 rescuer, it is 15:2. Okay, we'll see them also in anesthesia part. Don't worry, fine. And this is the motto of this neonatal resuscitation part. Then next. And they also ask you this about this epinephrine. You need to give usually by, if you have this IV access. If it is newborn, you will be having this umbilical venous catheter. Then you can add this, or you can give this drug from there itself. If nothing helps, then you can go for endotracheal route as well. Okay, all of these things. Okay, for IV, as I told you, right, 1:10,000. Fine, just go through this pharma parts. It is 1:10,000. Okay, whereas in the case of, we studied in anaphylactic shock, the dosage in the case of anaphylactic shock will give in IM. In such cases, will give in the more dosage, like 1:1000. Okay, yeah, right. Next, we'll move on to this transient conditions. They will tell you that there is a 3 and 4 days old child, or 3 to 4 days old newborn, and is presenting with this red erythematous rash on trunk. Okay, on trunk. Okay, what do you will think? What is the name of this rash? It is what it is. This erythema toxicum. This is the erythema toxicum. See, these are the transient conditions. Means if you do anything or if you don't do anything, these things will resolve by its own. So they are known as transient conditions. They will resolve by its own. Fine. So this is what this is. This erythema toxicum. And next, if you see, there is what this is sweat glands. If there is any blockage in the sweat glands, yeah. If there is any, yeah, reassure. Yeah. Then if you see the next one, it is this milia. So milia, it is what it is, the blockage of the sweat gland. So if you see about this glands, there might be different blockage. So okay, if it is kind of just liquid collection, it is just milia. If it is red colored one, it is known as milia rubra. So okay, so if you are able to see these small collections due to the blockage, this sweat glands, yeah, it is what it is, this milia. Next, if you are able to see this kind of changes, okay, this kind of changes over this forehead region, okay, over this forehead region. So then it is what? Then it is the stroke bite. Then it is what? Then it is stroke bite. Don't confuse it with this Portman state, okay. And next, if you are able to see, if there is increased maternal hormones, then it leads to this acneiform eruptions. It leads to this acne kind of eruptions. It is known as acne neonatorum. Yeah, good. It is known as acne neonatorum. It is due to the increased levels of maternal androgens. Due to increased maternal androgen. Okay. Next, if you are able to see this type of large pustules, okay, large pustules in the infant. If pustules present, it is known as pustular melanosis. And if you are able to see, only half side of body is getting discouraged. Okay, if the half side of the body is getting discolorized, then we'll call them as what? We'll call them as harlequin discoloration. We'll call them as harlequin discoloration. We'll call them as harlequin discoloration. Fine. And next, if you're able to see this type of bluish discoloration on back, it is known as Mongolian spot. If there is bluish discoloration on the back, it is known as Mongolian spot. Fine. And next, if you're able to see here, it is because of this maternal androgen, the same maternal androgen. If there is this type of thing where there is this breast enlargement, in this neonates, it is known as mastitis neonatum. It is also due to this increased maternal androgens. Okay, remember, okay, maternal hormones especially, right? Yeah. Next, if you are able to see this type of changes, like kind of marbling kind of changes due to the exposure to cold. As I told you, this baby inside the uterus, it will be having a normal warm temperature, whereas when it comes out, it will be exposed to this cold. So because of this exposure to cold, if there is skin changes like this, it is what it is this? It is the cutis marmorata. It is the cutis marmorata. Fine. It is just, remember, it is this hormonal changes. Okay, don't worry about this hormonal changes. Okay, because we know pregnancy means it is just a hormonal imbalance. Fine. And next about this part, which is this most important one, it is the neonatal jaundice. If you see about this neonatal jaundice, mostly previously they used to ask about the levels. Now they stopped asking about this level. First, you need to know about this neonatal jaundice. It will always go from this cephalocaudal progression. Fine. In the case of cephalocaudal progression, means it will start from the head and it will start involving this or go into the opposite direction. So in the case of seriously, if it is more than 12 or more than 12 milligram of bilirubin is there, then it will be staining the palm. So finally, see, if initially it will start from this phase under this cephalic phases, then finally it will into the palms and soles. So the palms and soles will be affected last. Palms and soles will be affected at last. Fine. And if this jaundice, if it involves this basal ganglia, it will lead to this type of thing which is causing this baby to be having this spasms, which is known as kernicterus. If the jaundice involving this basal ganglia, it is known as kernicterus. Fine. And there are two types of jaundice. Usually they will give you this history and they will ask you which type of jaundice is this, or which of the following is not seen in this typical type of jaundice. If you saw an infant who is presenting with hyperbilirubinemia, which is happening mostly after 24 hours, and it spontaneously regress, or it will regress by its own within 1 to 2 weeks. Within 1 to 2 weeks, it is getting regressed by things. But you know these things. But the patients, the child's mother, father, they won't understand this. So what they will do? They will insist you to check their child. So once you check which type of bilirubin will be increased in this case, is it conjugated bilirubin or unconjugated bilirubin, guys? Batao, which type of bilirubin will be commonly increased in a case of physiological jaundice? It is what? It will be always unconjugated. It will be always unconjugated, because if you see during this fetal life, yeah. So if you see this unconjugated bilirubin, it means we usually know, like once the baby born, and this RBC will break down and it will convert from this hemoglobin, fetal hemoglobin, to an adult one. Okay. So during this breakdown, there will be increased level of unconjugated bilirubin will be there, and there will be, it should be converted into the conjugated one. But we know this uridal glucourinal transferase enzymes, they available in very limited quantity. So if because of this very limited availability, this leads to this increase in this unconjugated bilirubinemia. This is usually what? This is usually physiological in nature, and we know it is water insoluble. That's why it is manifesting into the skin as yellowish. Right? This is the physiological jaundice. So it will appear after 24 hours. And it will be always unconjugated in nature. So as it is unconjugated, it won't go into the urine, means it won't be water soluble. So the child won't be having any urinary features. There will be no urinary features. Okay. And followed by this, if you see, it will resolve within 1 to 2 weeks. Fine. This is the physiological jaundice. Agar aap pathological jaundice ke bare mein baat karoge, then if you see about this pathological jaundice, this can be either unconjugated by hyperbilirubinemia or conjugated. Unconjugated kyun, sir? Because in such cases, for example, there will be some neonatal conditions, like for example, yesterday we studied, right? Crigler-Najjar syndrome, okay, then Gilbert syndrome. They can be causing this unconjugated one. Or if there is any cases of erythroblastosis fetalis, okay, where there is increased RBC lysis, okay. So in such cases there will be unconjugated bilirubin will be increased. So increased RBC lysis like erythroblastosis fetalis, or if there is any enzyme defect, okay, enzyme defect. Okay, fine. This is the usual things. Whereas in a case of conjugated hyperbilirubinemia, it will be increased. In a case of biliary atresia, it can be increased, or in a case of our favorite DR syndromes, like two syndromes, which is this DR, Dubin-Johnson and Rota syndrome, and biliary atresia. Okay, biliary atresia, there is this what the bile is found, but it is not unable to come into the duodenum part. That is the biliary atresia part. So, okay, fine. So, usually this pathological jaundice, it can be both unconjugated and conjugated in nature, and it will be it can appear within 24 hours. Can appear, okay, it can appear within 24 hours, and it will persist for a longer period of 2 to 3 weeks. It can persist for this longer period of 2 to 3 weeks. बस आपको ये सारी चीज याद रखना, फिजियोलॉजिकल को पैथोलॉजिकल्स के हम केस से डिफरेंशिएट करेंगे. ओके, recently, as I told you, right, recently they won't ask you about this calculation, mainly about this conceptual and theory part they will ask you, fine. And for such cases, okay, we'll convert this unconjugated bilirubin into this conjugated bilirubin by this phototherapy, and within this phototherapy will convert this unconjugated bilirubin to a compound which is known as lumirubin by this mechanism known as structural isomerization. Okay, then how will you tell? Because means there is a scale we use which is called Kramer scale, and we use this transcutaneous bilirubinometry. We can use this blood also, but for easy assessment we will use this transcutaneous bilirubinometry. So this is the instrument which is known as transcutaneous bilirubinometry, fine. And next, in severe cases, we know if it is will have this criteria, if it is more than 15 within this specific time, then we should go for this exchange transfusion. Exchange transfusion will do. See, that's correct. Dr. Puneet, if you see, during this phototherapy will cover this eyes and along their genital regions, okay, eyes and genital regions for prevention, okay, for prevention of this discoloration and things, fine. And usually the wavelength we use, it is 450 to 470 nanometer, and I told you the mechanism is what? It is the structural isomerism converting this unconjugated bilirubin to lumirubin, which is water soluble in nature, and it can be excreted, water soluble, okay, itna yaad rakho. Then what are the side effects? Kya ho sakta hai? One, the baby may become bronze, it is known as bronze baby syndrome. So we are exposing to this light, so there might be dehydration, watery diarrhea, and hypocalcemia, and sometimes gonadal and retinal toxicity. So इसी वजह से we cover the eyes and this gonads. So eyes and gonads बहुत important है, तो इसीलिए we'll cover this eyes and gonads. Remember. Then we discussed yesterday as well. Like if you see this conjugated bilirubinemia, okay, I told you it is DRC. Okay, doctors are always conjugated. Okay, doctors are always conjugated. So Dubin-Johnson syndrome and Rotor syndrome, these are these two conjugated hyperbilirubinemias. And if there is any biliary tract obstruction or biliary tract disease or what, or this biliary atresia, fine. And this unconjugated, it is usually physiological in nature, and it can be due to this increased RBC lysis, as I told you what, it is because of this erythroblastosis fetalis, or it is because of this Gilbert syndrome and Crigler-Najjar syndrome. Okay, Gilbert syndrome and Crigler-Najjar syndrome. Okay, itna yaad rakho. So this is the thing you should know in the case of, from the case of hyperbilirubinemia. ठीक है, jaundice के बारे में आपको इतना at least तो पता होनी चाहिए. Fine. And there is one more jaundice which you know is breastfeeding. Okay, and remember this breastfeeding jaundice, it occurs due to this decreased breastfeeding. Okay, breastfeeding jaundice में they will tell you will decrease the breastfeeding. Is it true statement or not? No, we won't decrease the episodes. We will actually increase the episodes of breastfeeding. बस थोड़ा आप याद रखना. Okay, then about this respiratory, फिर आगे बढ़ते हैं. Few neonatal conditions. One of them is what? One of them is this respiratory distress syndrome. If you see about this respiratory distress syndrome, it is most commonly seen in a case of preterm baby. We'll call them preterm baby if it is less than, if it is preterm baby, it is less than 37 weeks, we'll call them as preterm. Okay, and if it is very much preterm, like less than 34 weeks, then the lung is not yet matured completely. If there is no proper lung maturement, फिर क्या होगा? Then the baby will start having the respiratory distress. So usually they will tell there's a 33 weeks old baby or 33 weeks gestational age baby has been delivered, and now is presenting with features of respiratory distress after 3 hours of its birth. And what will be your initial stage of management, or what will be your diagnosis? The X-ray of the baby has been done here. So what you will think? What is the disease? Is this? It is what it is. This white out lung, also known as ground glass opacities, which we are able to see here, and this is classical feature of this respiratory distress syndrome, also known as this हाइलाइन मेम्ब्रेन डिसीज, आल्सो नोन एज दिस हाइलाइन मेम्ब्रेन डिसीज। इसको प्रिवेंट करने के लिए हम माँ को देंगे, क्या देंगे? हम माँ को स्टीरॉइड्स देंगे। विल गिव स्टीरॉइड्स टू द मदर टू प्रिवेंट दिस रेस्पिरेटरी डिस्ट्रेस। दैट इज इफ द बेबी विल बी डिलीवर्ड, फिर तब हम क्या करेंगे? वी नीड टू गिव सर्फेक्टेंट, क्योंकि हमें पता है इट इज ड्यू टू द डिफेक्ट इन दिस maturation of the surfactant which is produced by this type 2 pneumocytes। तो हम इनको पॉजिटिव प्रेशर वेंटिलेशन देंगे और बाद में सर्फेक्टेंट भी देंगे, ठीक है। फर्स्ट विल स्टार्ट विद दिस CPAP which is the positive pressure ventilation and followed by this surfactant replacement therapy and shifting them into this mechanical ventilation with ET tube, okay। So this is the usual scenario। So there is a child who is having this premature birth, and along with this there is a respiratory distress within or less than 6 hours of birth, then we'll consider of as respiratory distress syndrome, fine। And now you saw a child, you saw a newborn which is having the features of tachypnea, and asking history, the mother tells, means are the family members tells, they delivered the baby with cesarean section, yeah, with C-section, okay। We know when there is a normal vaginal delivery, the baby need to be compressed while coming out, so the baby will get compressed while coming out। लेकिन in the case of cesarean section हम तो आराम से baby को उतार लेंगे। So because of this, there will be fluid collection inside the lungs, lead to this kind of feature which is known as what? Transient tachypnea of newborn। So if you see this transient tachypnea of newborns, इसमें भी हम बिल्कुल कुछ नहीं करेंगे, इसमें हम बिल्कुल कुछ नहीं करेंगे, इसमें भी will give this conservative management with either oxygen support or just will monitor the baby। So it is known as transient tachypnea of newborn, okay, yeah। So it is what it is, this transient tachypnea of newborns। Here you will be able to see there is this presence of fluids. Here you will be able to see this presence of fluids in this interlobar fissures, and this sometimes this can be associated with this pleural effusion। As I told you, pleural effusion में हमें क्या देखेगा? There will be blunting of this clostophrenic angle, clostophrenic angle का blunting देखेगा। और in the case of Klebsiella pneumonia, see what is the in the case of Klebsiella pneumonia, what is the X-ray sign you will see? Yeah guys, can you please answer the yesterday we studied, what is the sign you will see in the case of Klebsiella pneumonia? In the case of Klebsiella pneumonia, remember, it is also causing this changes in the fissure, okay। Like see in the case of here in transient tachypnea newborn, you will be able to see there is this fissure will be having the fluid, that is known as fluid in the interlobar fissure। Whereas in the case of Klebsiella pneumonia, there will be typical X-ray sign, there will be a red currant jelly sputum, and there will be a typical X-ray sign where if you see, then you will tell, yeah, it is the disease which is being caused by this Klebsiella pneumonia, okay। So it is what it is known as bulging fissure sign, it is known as bulging fissure sign, it is known as bulging fissure sign, which is seen in a case of Klebsiella pneumonia, okay, on X-ray, yeah, fine। Next, you saw this baby who is presenting with the features of, now the baby is delivered at 42 weeks. At 42 weeks the baby is delivered. Now the baby is having the features of respiratory distress, okay, respiratory distress। So in the case of more than our postterm babies, if you are able to see, in the case of postterm babies, they are more prone to, the postterm babies, they are more prone to what? They are more prone to this type of aspiration, which is known as meconium aspiration syndrome। And in the case of meconium aspiration syndrome, you will be able to see this type of opacities, this type of opacities you will be able to see, and there will be what? There will be chemical pneumonitis, pneumonitis। So remember अगर वो बहुत मतलब if it is preterm baby and respiratory distress, आपको पहले सोचना है it is the respiratory distress syndrome। If it is postterm baby and presenting with respiratory distress, then you will think of meconium aspiration syndrome, fine। And then we'll move on to the next part। If you see, there is a child who is presenting with these features of bubble loop, this type of bubble loop present in the thoracic cavity, and along with this, like usually it will be the baby will be having the features of respiratory distress, and there will be this scooped out abdomen or scaphoid abdomen, okay, scaphoid abdomen, and on X-ray you will be able to see the presence of this bubble loops into this thoracic cavity. And in a case of this, which of the following is contraindicated? ET intubation or bag and mask ventilation? It is what? It is this bag and mask ventilation. Bag and mask ventilation is contraindicated. Bag and mask ventilation is contraindicated. Ventilation is contraindicated in the case of congenital diaphragmatic hernia. So in the case of congenital diaphragmatic hernia, the bag and mask ventilation is contraindicated. So we'll do ET intubation, ET tube. Okay. So remember, this type of congenital hernia, which is most commonly occurring at this left side. So remember, it is the right, this is the left. So this is the left side. So this is the left sided pleuroperitoneal defect. Pleuroperitoneal defect. And this will be manifesting as this type of congenital diaphragmatic hernia, which is known as Bogdalik's hernia, Whereas in right side, it is less common. Whereas right side, if you see, or behind the sternum, if you are able to see, this is known as Morgagni hernia, which is occurring on the right side. Whereas तुम्हें उसका याद रखने की जरूरत नहीं है. You should know this one, then you can rule out them, right? For example, this is this Bogdalik's hernia, which is occurring on the left side, where you will be able to see this bubble loops on the left side. Okay, bubble loops on the left side. ठीक है, इतने याद रखो. Fine. And next, you will be able to see there is a child. It is not infant. Now there is a child who is presenting with features of tachypnea and cough. Okay, and here you will be able to see there is this perihilar consolidations along with this hyperinflation, means you will be able to see more ribs than the usual. So if there is any peribronchial consolidations along with this hyperinflations, this is the typical for this bronchiolitis. Okay, this is for this typical for this bronchiolitis. Okay, can anyone tell me what is the most common causative agent for this bronchiolitis? Yeah, guys, what is the causative agent for this bronchiolitis? It is what it is, this respiratory syncytial virus. It is the respiratory syncytial virus. Yeah, respiratory syncytial virus which is causing this bronchiolitis. Okay, mostly we'll give this supportive care. Okay, supportive care. And for prevention, what we'll do? We'll give a drug which is known as pavlizumab. Okay, pavlizumab. 90 subjects, you can make this as your revision notes in your final part of time. And for short subjects, if you didn't touch, you can use this. Okay, there are very minimal notes, and make sure you are attending it, because if you see, notes is everywhere. You can download notes, you can see notes, you can use books, notes is everywhere. But thing is that understanding and how the questions are approached to the questions. If you know these things, then only you will be able to do. That's why I will ask you to attend the session, because I am giving the PDF because it will give you orientation what we are going to discuss. But if you don't know the connecting the dots, it will remain as dots. And in exam, you should connect one dot between one dot. Fine. And these short subjects, they are very much high scoring. Once you do this, you do 2 revisions of this, 2 to 3 revisions of these short subjects, just few more PDF writes, few more pages. If you do this, then mostly you will get all your questions correct. Okay, don't worry. Then, what is the most common cause of? If you see, the most common cause of, yesterday also we discussed, the most common cause of pneumonia, it is this Streptococcus pneumonia. Whereas second most common of this bacterial type, it is what it is, this Haemophilus influenzae. And viral pneumonia and bronchiolitis, it will be caused by this respiratory syncytial virus. Okay, whereas in neonates, it is group B Streptococcus more common than E. coli. Group B Streptococcus than the E. coli. Fine. Whereas we know in the case of HIV patient, it is what it is, Pneumocystis jirovecii. And which of the following organism will cause pneumatocyl formation? Bacteria. Okay, here bacteria. Pneumatocyl formations we saw in medicine part. Which of the organism will cause? Yeah, it is what it is, this Staph aureus. It is the Staph aureus. Okay, and in a case of pneumonia, radiologically we will be able to see this air bronchogram. See, this is the normal lungs we will be able to see. Here, in the case of pneumonia, everywhere there will be, means see, imagine this white as this fluids collection, or this because of inflammatory fluids. Whereas here you will be able to see proper airways, which is known as air bronchogram. Okay, air bronchogram. Yeah. Now, jirovecii, I told you, it can cause small pneumonias, but mostly in HIV patients. Whereas the Staph aureus, it is responsible for pneumonia by a bacteria and causing this pneumatocysts and causing the pneumatocysts. Then we'll move on to this congenital heart disease part. If you know about this congenital heart disease part, mostly they will try to ask you, either giving X-ray, they will ask you to diagnosis, or they will ask you, is this cyanotic heart disease or it is a non-cyanotic heart disease or acyanotic heart disease. बस आपको इतना differentiate करना. Remember about this cyanotic heart disease, आप कैसे differentiate करोगे? The most of the, remember it is most of the cyanotic diseases, it will be having this name in their T in their name. Okay, so if you see first one, there will be two separations in this. One is this decreased blood flow, okay, decreased blood flow to the lungs, and one there will be increased blood flow to the lungs. For example, in the case of tetralogy of Fallot, first see this mnemonic, all of them T, tetralogy of Fallot, tricuspid atresia, okay, and here the pulmonary valve stenosis. Next, that is the transposition of great arteries and TAPVC, yeah, TAPVC, yeah. That is the T, which is this cyanotic heart disease. Good guys. Then if you see in a case of tetralogy of Fallot, you understand the physiology. We know there will be pulmonary stenosis. Agar pulmonary stenosis hai, how the blood will go from the heart to the lungs. So there will be no or very less blood will be flowing to the lungs. So stenosis ki wajah se. So there will be because of decreased pulmonary flow. फिर उसके बाद tricuspid atresia. Okay, tricuspid from right atrium to the left atrium, we need to have this tricuspid valve. If there is no valve, then it will go by this shunting or by this ventricular septal defect only. So there will be, obviously there will be a less blood flow there. Whereas increased blood flows in a case of transposition of great arteries. If the great arteries, what are the two great arteries? This pulmonary artery and this aorta. If instead of originating from this right ventricle, the pulmonary artery, if it is originating from this left ventricle, from this aorta, instead of originating from this left ventricle, it is originating from the right ventricle, means they are transpositioned. Instead of like this, they are transpositioned. It is known as transposition of aorta, and because of this, this pulmonary artery will be connected to the left ventricle. और हमें पता है, in a case of left ventricle, it will pump more blood than compared to this right ventricle. Okay, just remember this thing. Okay, next, fine. This is transposition of great arteries. Then total anomalous pulmonary venous return means instead of usual return, what will happen is all of this blood, it will come and return to this unanimously to this atria. Okay, because of this, what will happen is the same circulation. Instead of going to the left atrium, it will come into the right atrium only. So same circulation under this pulmonary circulation will happen. So there will be a more blood flow. Okay, this is the congenital heart disease which are cyanotic part. Whereas acyanotic, all other than T ones. Like for example, our ventricular septal defect, our atrial septal defect, or atrioventricular septal defect, are this endocushing defects. Fine. Next, this patent ductus arteriosus. Fine. Can you tell me patent ductus arteriosus? In this ductus arteriosus, it is which arch of artery? It is what? It is this left sixth arch artery. It is the left sixth arch artery. Then obstructive lesions like aortic stenosis, pulmonary valve stenosis, and coarctation of aorta. Most of them, they are also acyanotic. And these are the X-ray findings they will give and they will ask you. For example, if you are able to see this side of egg of string or egg on side appearance, it will be suggestive of transposition of great arteries. It is suggestive of transposition of great arteries. Yeah, in the case of patent ductus arteriosus, you will see this continuous machinery murmur. It will mention, you will be able to see the continuous machinery murmur. What is the drug you will give? Ibuprofen more than the indomethacin. Okay, it is which arch artery? It is a left sixth arch artery. आपको बताना. Next, because of this total anomalous pulmonary venous return to this right atrium, it will be in this shape which is known as 8 or this snowman appearance. Okay, snowman appearance are also known as figure of 8 appearance. Yeah. Next, if you are able to see, there is no segregation of this ventricles and everything. So here leading to this atrialization of this ventricle. Causing this box-shaped heart which is known as Epstein's anomaly. Atrialization. Okay, yeah. It is due to this lithium use. Yeah, it is one of the causes, this lithium use in pregnancy. It is the atrialization of ventricle. Atrialization ventricle. Fine. Yeah, good guys. Fine. Yeah, it is the box shaped heart. Next, we'll move on to the next part. If you're able to see this type of Schmitter appearance, it is what it is. Instead of total, if it is just partial, it is known as partial anomalous pulmonary venous return. It is known as Schmittasa. Okay. Next, if you're able to see this type of goose neck deformity, like this goose, there is this neck formation. It is known as what? It is seen in a case of endocardial quotient defect. And we know this endocardial quotient defect, it is most commonly seen or typically seen in a case of Down syndrome. Okay. Next, if you're able to see this formation of 3, okay, formation of 3 or this reverse 3 sign, it will be typically seen in a case of coarctation of aorta. And in the coarctation of aorta, you will be able to see there is this presence of this inferior rib notching. There will be presence of this inferior rib notching. There will be presence of this inferior rib notching as well. Fine. And next is the tetralgia fillet. Okay. Tetralgia fillet, also known as core ends about, are also known as boot-shaped heart. Boot-shaped heart, it will be having this VSD, overriding of aorta, right ventricular hypertrophy, and along with this there is a pulmonary stenosis. Can anyone tell me what is the most important, or which of the following feature in this tetralgia fillet will define the severity of this tetralgia fillet? Yeah guys, which of the following will define the severity of this tetralgia fillet? It is what? It is this pulmonary stenosis severity. Then we'll move on to this score, which is known as APGAR score. In APGAR score, first A for appearance. Okay, the minimum score is 0. Okay, and the maximum score is 1, 2, 3, 4, 5. 5 into 2, it is what? It is 10. Fine. This it's 10. Fine. Next, so appearance. If the appearance of the baby is just blue or completely cyanotic, then we'll give 0. Cyanotic. Then if the baby is having cyanosis over this limbs or the end of the limbs, we'll call them as acrocyanosis. So acrocyanosis will give 1 point. Okay, whereas in a case of just normally pink baby, if it is just this pink baby, then we'll give a score of 2. Fine. And in case of pulse, we'll see if there is no pulse. If it is, then we'll give 0. If it is less than 100, we'll give 1. If it is more than 100, we'll give 2. Fine. Next, about this grimacing. Once you stimulate with this, either with nasogastric tube, then if the baby is not responding, if you are stimulating with this nasogastric tube, usually the baby will cough or sneeze. Fine. So if the baby is not responding, it is 0. If the baby is making some odd facial expressions, it is known as grimacing. Fine. It is known as grimacing, which will be given 1 point. Whereas if the baby is coughing or sneezing, then it is what? Then it is this score of 2. Score of 2. Okay, score of 2. Fine. And next, score of 2. Pink means it is 2 only. Okay, that is pink means it is 2. Remember. Then about this activity, it is what? It is this no movement, some movement, and active movement. Means when you stimulate or when you see the baby, if there is no movement, it is what it is. If the child is flaccid or something, it is score of 0. Or if there is only few movement or something movement is there, it is 1 score. And if it is active movement, it is this 2 score. Okay, 2 score. And about respiration, if there is no breathing or if there is weakened irregular breathing, and if the baby is having the strong cry or shrill cry, then it is 2. Okay, remember about these 2 points only. Okay, first appearance, it is completely blue and the limbs blue to the pink. Next, pulse 0 or absent. If it is less than 100, it is 1. If it is more than 100, it is 2. Then about grimacing, there is no response, 0. If it is having some grimacing experiences, it is 1. And if the baby is able to cough or sneeze, it is 2. Fine. Next, about activity, if there is no movement, it is 0. If there is some movement of flexion, it is 1. And if it is normal movements, it is 2. Fine. Next, about the respiration, if there is no breathing or apnea, it is stage as 0. And if there is any few breathing efforts or irregular breathing, it is score of 1. And if it is normal breathing along with this shrill cry or this rapid cry, it will be having a score of 2. Okay, okay, the maximum score of each part it is 2 and the maximum score is 10. Fine. It is used to assess this, assess how the baby will progress based on this resuscitation. Okay, remember. Next, about this IMNCA guidelines for this. Yeah, for this IMNCA guidelines, you will see about this pneumonia and dehydration management. You should know this. Fine. In a case of pneumonia, तुम्हें पता है कि if there is no signs of pneumonia or no signs of very severe disease, or if there is no signs of fast breathing, or if there is no signs of chest interaction, just this common cold and thing, we'll consider, yeah, it is not pneumonia. We'll just give them the home remedies and we'll send home for the treatment. Fine. And if there is presence of fast breathing component, okay, how will you tell it is a fast breathing? See, in the case of fast breathing, if the child or if the infant is less than 2 months of age, then we'll tell if the breathing is less than 60 or if the breathing is 60 breaths per minute, we'll tell, yeah, if the child is having fast breathing. And if the baby is 2 to 12 months of age, and if the baby is having more than 50, so remember till 2 months it is 60, and 2 to 5 months, 2 to 12 months, it is what it is, this 50 breath, whereas 12 to 5 years, it is what it is, this 40. Okay, so 60, 50, 40, 60, 50, 40. If it is more than 40 in a 5 years old child or 3 years old child, will tell them that the baby is having tachypnea or fast breathing. So once there is a presence of fast breathing, you need to intervene. We'll diagnose it as pneumonia. We'll diagnose it as pneumonia. Then if you diagnose it as pneumonia, just simple pneumonia, then you should tell about the danger signs. What can be the danger signs? The child won't eat. If the child is not eating for a few days, or if the child is not drinking water for a few days, then bring to us immediately. And so that like that you will counsel to the mother. Like I say dekho, okay, you will counsel them. Once you counsel them, and you will give them antibiotics like amoxicillin for 5 days, and you will send them home. Okay. And next, if you are able to see if there is presence of this both, any of these danger signs along with this chest in drawing or stridor in a calm child, then you will think it is a case of severe pneumonia or very severe disease. There is no such classification of very severe pneumonia. It is severe pneumonia, also known as very severe disease. Okay. In such case, what you will do, if you are in very much periphery, you will give first dose of ampicillin or first dose of antibiotics or amoxicillin. Okay. Yeah. First dose of amoxicillin or any antibiotics, or usually amoxicillin will prefer, then we'll send to this higher center. Fine. Then to the higher centers. Fine. Yeah, previously we used to have this chest in drawing, either fast breathing or chest in drawing, but now we usually consider only fast breathing as a component. Okay. Remember. In the case of fast breathing, just pneumonia, we'll call them after 2 days. Okay. It is categorized as yellow, whereas in the case of severe pneumonia, it is categorized as pink, and after giving this first dose, if you are in the periphery, it is referred to the higher center. Okay, this is the usual component. Next, about this development of milestones. Fine. We'll see about the dehydration part soon. Then we'll see about the development of milestones. See, if you see about this development of milestones, you need to know this also happens in cephalocaudal progression. Okay, first the baby will start holding its neck at 3 months. Then around 6 months and 4 months, it will roll and turn around. It will turn around 4 months, and 6 months it will sit with support. Remember, 6 months sit with support. Once it starts sitting with support, then it should sit without support. So around 8 months it will, it is a tripod position, and 8 months it will sit without support, and 9 months it will what? It will stand with support. So remember, 6 months sit with support, 8 to 9 months, 8 months it is sitting without support, 9 months it is standing with support, and 12 months it is stand without support. Okay, 12 months it is standing without support, and after 15 months it will start walks independently, and 18 months it will start running. And 2 months or 2 years it will start climbing the stairs with 2 steps. Okay, 2 steps per foot. Okay, 2 steps per foot it will start climbing. Whereas 3 years, what it will do? It will go up with alternate foots, but it cannot come down. And 3 years it also rides tricycle. And around 4 years it can go up with alternate foots, like 1 foot here, 1 foot here, 1 foot here, 1 foot here. It can go up also, and it can come down also. It can come down also at the age of 4 years. Okay, just remember about this. These are the important motor milestones. First, the baby will start holding neck around 3 months of age, and 4 months the baby can turn, and 6 months what will be? It will be sitting with support, and around 8 months it will sit without support. Then it will stand with support. Then it will stand without support, and 12 months it will stand without support, because it's a birthday. Okay, so it's need to cut the cake, right? So it will, without support only it will cut the cake. So around 15 months it will be start walking independently, and around 18 months it will start run. Then around 2 years it will go alternate, means it will go along with this 2 foot per step, whereas at 3 years it will go alternate steps in the upstairs directions. Fine, whereas it cannot come down. Whereas in the case of 4 years it can go also with 1 by 1 foot, and it can also come down. Okay, and at the same time, the 3 years, what will happen? It will draw the circle, and it will ride a tricycle. Remember. Fine, bas itna yaad rakho. Yeah, I will like this is a sequential involvement. I'll tell few mnemonics when it's necessary. Okay, see, this 3 years, it is 3 try. So 3 years में क्या करेगा? Tricycle ride करेगा. 2 years में क्या होगा? 2 years में 2 foot per step रहेगा. Okay, and about a few important ones, I will tell a story so that you can remember the important one at least. Fine. फिर उसके बाद बस पहले मुझे बस बेसिक्स आपको मोटा समझा देता हूँ. Then I will tell you the mnemonic if you are unable to remember all these things. Fine. Then about this language milestones, 3 months the third alphabet C, so it will be squeeing. Then 6 months it will be ma pa करके, means एक ही करके बोलेगा ma pa. 9 months it will say bisyllable, it is mama papa. Okay, it is mama papa. Okay, yeah, 3 months it is cooing. Okay, then around 1 years it will speak 1 to 2 words. If they say what, around 1 year they will say happy birthday, so it should tell 1 to 2 words thank you. Okay, it will tell thank you. Okay, so that is what in that is 1 to 2 words. Fine. In about 15 months it will speak very randomly. Okay, that is known as jargon speech. कुछ भी बकेगा. It is around 15 months. Then around 18 months it will speak around 8, like 10 plus 8, it is 18. So 8 plus 8 to 10 words it will speak. And 2 years क्या करेगा? 2 sentence की words बनाएगा. It will make 2 sentence words. Okay, it makes 2 sentence words. And 3 years में it will know 3 things. 3 years में वो it know 3 things. It can tell its name, age and gender. एज नेम एंड जेंडर. ठीक है, फिर उसके बाद अबाउट दिस सोशल माइलस्टोन्स. ठीक है, अराउंड 3 months it know mother's regard, like mother's regard, and 6 months it is S for S, it is the danger anxiety. Yeah, around 3 years it can ask questions, and 4 years it can tell stories as well. Fine, stories as well. Fine, around 9 months it will tell bye bye, and 12 months it can play with a simple ball, and 2 years it will play parallelly, and 4 years it will do ground play, so group play. So that's why in 4 years what we'll do, we'll start sending to this pre-KG classes. Right, that is the 4 years. And about this next one, it is this motor milestones. And about this motor milestone, it is also sequential. For example, पहले क्या करेगा, hand records या क्या है, अपनी हाथे करके it will just see, यार मेरे पास हाथ भी है करके it will see. Fine, next one क्या करेगा, जो भी तुम दोगे उसको वो palm से पकड़ेगा. Okay, it will start grasping into this palm. It is known as palmar grasp. Okay, next around 5 months जो भी आप दोगे it will start holding in 2 hands. It is known as what? It is known as bidextrous grasp. अगर around 5 months it will, around 4 to 5 months it can hold a thing with both the hands. ठीक है, सपोर्ट के लिए. फिर उसके बाद क्या करेगा, इसको इस हाथ में देगा. So and 6 months it will be what? It will be unidextrous grasp. It will be what? It will be unidextrous grasp, means एक ही हाथ में पकड़ेगा, means with one hand it will hold it. Fine, around 9 months there will be this, see, this is mature pencil grasp, like this mature है ना, ठीक है ना, जैसे हम लिखते हैं. Whereas if you see like this, if the child holds it, is known as immature pencil grasp. इसका नाम है immature pencil grasp. Okay, immature pencil grasp. Whereas around 12 months this will be just like mature, like you. So it is what it is, mature pencil grasp. Fine. And जैसे फिर तो पेन तो उठा लिया, फिर उसके बाद क्या करना, it will start scribbling. It will start scribbling by 15 months, and फिर उसके बाद it will start making something. तो क्या करेगा, तो अराउंड 18 months जैसे स्क्रिबल कर रहा था तो उसका एक सैचुरेशन पॉइंट हो जाएगा. तो व्हाट विल डू, इट विल स्टार्ट अ लाइन. It will draw a line around 18 months. It will draw a line around 18 months. Okay, and yeah, on 15 months it will build 2 cubes. And 18 months से, remember it is 15 plus 3, it is 18. 18 months में 3 cubes build करेगा. Okay, and it can feed with food. ठीक है. Then around 2 years क्या करेगा, it also start to copy the lines as well. Fine. Around it can build up to, इसको बाद means after this you need to multiply with this number. So if it is 3 cubes in 18 months, then 2 into 3, it is 6. Then around, if it is 3 years, then it will be around building around 9 more. Okay, so it around 3 years क्या करेगा, it will copy a circle. So remember, 3 years it will write a tricycle, third alphabet tricycle, and 3 years, see, this is the circle. It will form the face, right? So you should keep the years. Okay, years. So remember, it is years, it will tell the year. So it is the 3 year, it will make the circle at 3 years. ठीक है, फिर उसके बाद क्या बनेगा, मीन्स इट विल, उसका गर्दन होगा, गर्दन में मीन्स इट विल बी वेयरिंग दिस, मतलब इसका क्रॉस. ओके, द क्रॉस इट कैन मेक इट अराउंड 4 years. ओके, तो इसको जैसे गर्दन होता, देन द बॉडी शुड कम, राइट? सो इन द बॉडी व्हाट विल डू, इट विल मेक दिस काइंड ऑफ रेक्टेंगल. सो इट विल बी व्हाट, इट इज द 4.5 years एज, इट विल मेक दिस रेक्टेंगल. ठीक है, रेक्टेंगल. ठीक है, तो जैसे बॉडी बनाएगा तो नीचे के भी बनाना ना, तो इट विल मेक फर्स्ट, बिफोर मेकिंग इट विल मेक अप द ड्रेस. ठीक है, तो अराउंड 5 years क्या बनेगा, इट विल मेक अप द स्कर्ट विच इज इन ट्रायंगल शेप. दिस ट्रायंगल इट विल मेक अप एट 5 years. ठीक है, आफ्टर, फिर उसके बाद नीचे क्या रहेगा, बूथ तो नहीं है ना, तो देयर विल बी पैर, so there will be leg. So this leg, it is in diamond shape, so it will be of, it will be around 6 years it will make this diamond. Okay, 6 years it will make the diamond. Okay, so these are the 5 motor milestones you should remember. अगर आपको इतना सारा याद रखने में थोड़ा बहुत दिक्कत हो रही है तो just see a few things. For example, 3 months में पहले गर्दन को मीन्स इट विल होल्ड नेक and 3 months, okay, month, ठीक है. तो because of this 3 months, it is third alphabet, it will do cooing, ठीक है, cooing करेगा, okay. And next is the 6 months, okay, 6 month. Remember 6 months में सारे S से शुरू होगा. Remember 6 months में, ठीक है, it is like a single or सख्त लौंडा, or this single child, or this means single means in the sense of single and committed, वो वाला single, ठीक है, it is single. अगर वो single है, वो क्या करेगा? What it will do? It will use his hands, ठीक है, कैसे? It will try to grasp its phone and it will try to text, okay, it will try to text. So it is what? It is the single one, it will use the single hand to take his phone and text, okay. So it is what it is, this unidextrous grasp, this is unidextrous grasp. और अगर सिंगल है तो किससे बात करेगा, किससे टेक्स्ट करेगा, किससे बात करेगा? वो माँ से और पा से, ठीक है. सो इट विल बी हैविंग दिस मोनोसिलेबल्स, इट विल बी हैविंग दिस मोनोसिलेबल्स, या गुड. देन अगर मोनोसिलेबल से बात करेगा फिर कुछ टाइम के बाद क्या होगा, वो थक जाएगा. मींस वंस ही गेट्स टायर्ड, ओके, और बिकॉज ऑफ दिस यूजिंग हिज सिंगल हैंड फॉर दिस फोन्स, कुछ टाइम के बाद थक जाएगा. देन ही विल बी सिटिंग विद सपोर्ट, सो ही विल बी सिटिंग इन ट्राइपॉड पोजीशन, ठीक है, ट्राइपॉड पोजीशन व्हिच इज दिस सिटिंग विद सपोर्ट, ठीक है, सपोर्ट के साथ सिट करेगा. जैसे वो सपोर्ट के साथ सिट किया फिर उसके बाद क्या होती, अगर वो घर में बैठा है, ठीक है, तो कोई ना कोई तो घर में तो रिश्तेदार आ जाते हैं. अगर लौंडा 25 साल का है तो मींस इफ द बॉय इज अराउंड 25 इयर्स एंड ही इज स्टिल सिंगल, सारे क्या जो रिश्तेदार आते हैं वो सारे मार्क करते रहते हैं. तो इसीलिए अगर जैसे वो रिश्तेदार आया वो भागने का कोशिश करेगा. तो सी इन अ केस ऑफ दिस 6 months यू विल एबल टू सी व्हाट, यू विल एबल टू सी दिस स्ट्रेंजर एंजाइटी. स्ट्रेंजर एंजाइटी, रिश्तेदार सारे स्ट्रेंजर्स होते हैं ना, तो रिमेंबर इट इज अ स्ट्रेंजर anxiety, okay, remember. So it will be 6 months single hand unidextrous grasp, फिर उसके बाद it will say monosyllables ma pa and it will be sitting with support in a tripod position and it will be having this stranger anxiety, ठीक है, ठीक है, good. I guess it is making you to remember, ठीक है ना. at the end of the day तुम्हें याद रहना, ठीक है. then we'll move on to this next part. 12 month पे क्या करेंगे? 12 month पे the baby means आपका बर्थडे आया, ठीक है, बर्थडे आया तो पहले डस्टअप अच्छा से करना, फिर उसको क्या करना, केक कटवाना है. अगर केक कटवाना है तो यू शुड नो मींस हाउ टू कट इट जेंटली, राइट. एंड बिफोर कटिंग द केक यू शुड मींस इट्स नॉट लाइक इफ आई सिट एंड कट इट वोंट बी गुड लुकिंग गुड, राइट. सो आई शुड स्टैंड एंड थिंक. सो रिमेंबर इट इज स्टैंड विदाउट सपोर्ट अराउंड 12 months, ठीक है, स्टैंड विदाउट सपोर्ट करेगा. एंड उसको या सर यू लर्न हिंदी, या आई लर्न हिंदी विथ माय फ्रेंड, ओके. So if you see about this cutting of this cake, if you see the cutting, मतलब अगर immaturely cut कर देंगे ना तो थोड़ा गेट नहीं है ना यार, 1 साल हो गया, फर्स्ट बर्थडे है, ठीक है ना. देन व्हाट यू डू, यू कट विद जेंटली, ठीक है ना, जैसे फोर्सली, ठीक है. सो इट इज व्हाट इट इज नोन एज मैच्योर पिंसर ग्रास्प, मैच्योर पिंसर ग्रास्प. हम जैसे वो बोलेंगे बेटा कंग्रेचुलेशंस बेटा, तो क्या बोलना है, एक दो शब्द तो बोलना ना, यू शुड टेल 1 to 2 words, that is what around 12 months it will speak 1 to 2 words, okay, 1 to 2 words बोलेगा. फिर उसके बाद जो भी आएंगे, ठीक है, ठीक है, जो भी आएंगे तो you will start walking. So just remember all these things, stand without support, mature pencil grasp and 12 words. And finally वो किसके पास जाएगा, वो मामा और पापा. So it will tell this bisyllable words, it is mama papa, mama papa, okay, just remember. And next we'll move on to 18 months. Remember 18 साल पहले हम सारे घर में थे, क्या करते थे, क्योंकि हम बच्चे थे, ठीक है. वी वर इनसाइड द होम और वी वर लिमिटेड विद फ्यू थिंग्स बिकॉज वी वर वेरी किड्स, और वी वर किड्स, वी जस्ट फिनिश्ड आवर इंटरमीडिएट just 18 months back, but like around this 18 years, remember this 18 years to 18 months, okay. So just correlate with your lifestyle. Then we know after 18 months क्या होगा, तो हमें क्या होना कि घर से बाहर आके पढ़ाई करना है. मींस यू शुड कम आउट, इधर यू शुड गो अब्रॉड, यू शुड स्टडी, सो दैट, तो इसलिए आपको क्या करना है, घर से भाग के आना है. यू शुड रन एंड यू शुड कम आउट ऑफ इट. तो ठीक है, तो उससे पहले आपके साथ एक लिमिटेशंस थी, तो लिमिटेशंस मनाने के लिए एक लाइन के अंदर थे आप, ठीक है, आपकी जिंदगी. तो इफ इट इज योर एंटायर लाइफ विद इन अ लाइन, फर्स्ट यू शुड नो हाउ टू मेक अ लाइन. सो अराउंड 18 months इट विल मेक अ लाइन, ठीक है. देन इट विल ट्राई टू क्रॉस द लाइन, सो इट विल क्रॉस बाय रनिंग. So it will runs around 18 months. ठीक है, भाग के बाहर आएगा. When you come out of it, then you know the values of your mother and values of your family. ठीक है, तो अगर if you come out, you know you need to do work with your hands. ठीक है, you need to do work. तो कैसे आप काम करेगी? Means if you do work, it is what it is. You are building the cubes. You will build 3 cubes. Then you need to prepare food. ठीक है ना, ये जैसे आप बाहर आएंगे तो खाना भी आपको बनाना है, बर्तन भी आपको धोना है, मीन्स यू शुड वॉश योर यूटेंसिल्स बाय योरसेल्फ ओनली, नो मम्मी आके तो नहीं धोंगे. तो रिमेंबर यू विल डू दिस थिंग व्हिच इज नोन एज डोमेस्टिक मिमिक्री. मतलब the small child, what it will do, it will start to mimic its parents, like washing the dishes, washing the clothes, it will start to mimicking. So domestic mimicry, it will be happening at the age of 18 months. 18 months. फिर तो सबसे तो मतलब मेन चीज हम किस चीज के लिए बाहर रहे हैं, मीन्स व्हाट इज द मेन रीजन यू कम आउट ऑफ योर होम, आपको पढ़ना है. सो द बेबी विल स्टार्ट flipping the pages, so it will start flip 1 to 2 pages. Yeah. तो एंड आई टोल्ड यू राइट, डोमेस्टिक खाना भी आपको खुद बनाना है, बर्तन भी आपको खुद धोना, तो इसीलिए इट विल स्टार्ट फीडिंग विथ स्पून. ठीक है, वो स्पून से फीड करेगा. ओके, स्पून से फीड करेगा. और लोग से बात भी करना, तो इट विल बी हैविंग दिस 10 + 8, सो देयर विल बी 10 + 8 words. ठीक है, तो रिमेंबर इट विल रन, it will make a line, and it will be having build cube of 3 cubes, and it will do all these domestic jobs, which is known as domestic mimicry, and it will turn 1 to 2 pages. So it is the mnemonic for the 18 months. फिर उसके बाद आते हैं 3 years पे. ठीक है, अराउंड 3 years. ठीक है, 3 years मैंने बोला द बच्चा विल राइड ए ट्राईसाइकिल. ठीक है, राइड ए ट्राईसाइकिल. ठीक है, जैसे बच्चा ट्राईसाइकिल चला रहा था. ठीक है, क्या हो गया, मीन्स द बेबी वाज राइडिंग द ट्राईसाइकिल. नाउ द ट्रैफिक पुलिस ही गॉट द अटेंशन, सो ही केम टू द बेबी. ठीक है, इफ ही केम टू द बेबी, अगर जैसे पुलिस इनके पास आता है, तो व्हाट आर द 3 क्वेश्चंस ही विल आस्क. नाम क्या है. ठीक है, then what is name, age and gender. So at 3 years it can tell 3 things, which is this: name, age and gender. ठीक है, नेम, एज एंड जेंडर. ठीक है, या इट कैन टेल 3 things, which is नेम, एज एंड जेंडर. ठीक है, ठीक है, तो पूछा लाइसेंस दिखाओ, तो देन इट टोल्ड व्हाट इज योर नेम, एज एंड जेंडर इट टोल्ड. देन फिर भी वो ट्रैफिक पुलिस नहीं माना, क्योंकि ये छोटा बच्चा कैसे चला सकता है, तो इसीलिए ही टोल्ड यूजुअली फॉर अस टू गेट लाइसेंस विल मेक 8, लेकिन ये छोटा बच्चा है, 8 तो नहीं बना सकता, तो इसीलिए क्या बोले, ठीक है चलो तुम एक सर्कल बना के मुझे दिखा दो. तो अराउंड 3 years it will make a circle. So around 3 years it can ride a tricycle. It knows 3 things, which is age, name and gender, and it can form a circle. Fine. So these are the 3 things you should remember from this 3 years of age. Okay, if you are unable to remember all other things, just remember these things, it will be helping out. Okay, it will be helping out during your examination part. Okay, yeah, 3 into 3 it can make a cube of 9 cubes. Yeah, 9 cubes. Yeah, good, Dr. Puneet. Yeah. Next, about this few syndromes, if you see about this Down syndrome, here also have a small story. Fine, I'll tell you. Fine, if you see this Down syndrome guy is down at 21 years. Is down at 21 years. Q? Because why is down? Why is sad? The 6 months old. He's single. Okay, see, there will be always one person in every gang, either your roommate or your classmate, will be always talking to either boy or a girl. But if you ask, kya hua? Means are you committed? They will tell, no, I'm single. Okay, so these people will be, there are few exceptions will be like that. So during preparation part, they actually become single. So when you ask them, are you single now? At 21 years, how will you be single? But the answer for them, there is no answer they didn't told. They just showed their hand. Okay, yeah, see, I'm single. Like with hand, how will you tell it is single? We can't tell. See, if you see this hand, there will be this Down syndrome baby will be having this hand, which is known as single simian crease, like epidraw. Okay, see, if you see, there will be what? There will be single simian crease. So there will be single simian crease. Yeah, simian crease. And why it is single now? Because it had only one girlfriend or a boyfriend. Okay, the child had only, like, remember it is a boy, so only it has only one girlfriend, and someone took away her girlfriend. Okay, his girlfriend. So who is that? So if you see who, because the girlfriend broken his heart. So here you will able to see this cardiac condition, which is known as endocardial cushion defect. Because his heart is broken because of this endocardial cushion defect. Who broken his heart? Because this Robertsonian translocated his girlfriend. So this Robertsonian translocation is seen here. Because क्या हुआ, कौन इसका दिल तोड़ा? क्योंकि रॉबर्टसोनियन ने इसका गर्लफ्रेंड को उठा लिया, तो उसने इसका दिल तोड़ दिया. So having this heart feature, which is what was this endocardial cushion defect, because of this Robertsonian translocating his girlfriend. So remember, it is the Robertsonian translocation. Fine. And next one, if you see, he'll be single. He won't be roaming in good kapade. Means he won't be roaming in good clothes. He'll be roaming with this simple sandals. So he will be having this sandal toes. and in some part of time he tries to remember everything. Okay, so he will be having what? He will be try to forget everything. So he will try to forget all. So the most common type of leukemia, it is what? It is ALL. It is the most common leukemia in the case of Down syndrome. It is the ALL. And so because he want to forget, the God will give you his varam. So that is what that is, this pre-senile Alzheimer's. Okay, Alzheimer's. Remember, yeah. So that's what, like when he shows his hand, he will tell like find me whether I'm single or not, like that. Like I will see until he's single. Then he will ask Epudra, like cycles Epudra. Okay, then about this one, there will be what? There will be this pre-senile Alzheimer's. Fine. So these are the things. Like here you will able to see this heart condition, which is known as endocardial cushion defect. And why there is heart condition? Because the Robertsonian translocated his girlfriend, which is known as Robertsonian translocation, and he tries to forget everything. That the most common leukemia, it is ALL. And then if you are able to see preclinical Alzheimer's, like pre-senile Alzheimer's, so that he will get Alzheimer's in very early age. It is not Kyapudra, it is Epudra. Means there is a meme, it is known as Epudra, like that. So you just go and see. Okay, it is a Tamil meme. Okay, means Epudra means Epudi, means how. Okay, so there is a small child, it will be doing some thing like it will be playing with the rubber band, and while doing, it will remove it. So it will ask you Epudra, means how it is happened. Okay, the same thing. Okay, so likewise we'll see the hand and we'll diagnose likewise Epudra, how you diagnose with the hand. Okay. So the patient will be having this sandal toes. Okay, the patient will be having this sandal toes. Okay, and we know this usual Down syndrome features, which is this macroglossia. There will be this Mongolian slant of eyes. Yeah. So, okay, so these are the features you need to know about this Down syndrome. Next, आगे बढ़ते this syndromes. Okay, so these are the Down syndrome का features है. तो इतने आपके याद रख लिया. फिर उसके बाद है Turner syndrome. Okay, Turner syndrome. Yeah. Turner syndrome. So if you see here, we talked about this boy, which is Turner. Okay, next we saw about this. We'll see about this Turner syndrome. ठीक है, Turner एक लड़की है. ठीक है, Turner एक लड़की है. वो छोटी सी लड़की है. लोग प्यार से हम like चुटकी बुलाते हैं ना. तो like there will be a small girl. ठीक है, and she will be roaming in the classes. So she will be roaming in the classes like this. So one day this boys and some other girls, class girls, they try to mock her. Okay, कैसे mock करते? Oh, like that they will call this girl, and whenever she crosses. So it is what it is, 45XO. It is what it is, 45XO. So they will call this child as oh. So it is 45XO. And one means it is not every day. It is her like she's got already mad and pissed off with it. So she tried to reply them back. How? She want to turn and to reply them back. But while she was trying to turn, she unable to turn. Why? Because she was having this necks. So she was having this webbed neck, she is unable to turn. So remember this, she is turning, so it is this Turner syndrome, and she will be having this short stature, as I told you. Okay, chutki. So she will be having this short stature, and then she is trying to turn. It is known as what? It is known as Turner syndrome. Okay, and here there is but she is a girl, she is not single, so she is mingle. Why? Because she also having a heart defect which is similar to his boyfriend, which is this Noonan syndrome. In the case of Turner syndrome, it is associated with this bicuspid aortic valve and coarctation of aorta. Whereas the male counterpart of this Turner syndrome, it is what? It is this Noonan syndrome, which will be having this pulmonary stenosis. Pulmonary stenosis. Okay, and both of them, they maintain streak in the Snapchat. So she will be having the streak ovaries. See, Turner syndrome, it is especially seen in ovaries, whereas the male counterpart of it is known as Noonan syndrome. Whereas this Noonan syndrome can be seen in both males and females. So Turner, everyone is calling she is trying to turn, so that is Turner syndrome, and she is unable to turn because she was having the webbed neck. Okay, she was having this webbed neck, but she want to reply back, so that's why she called her boyfriend. How they became boyfriend? Because both of them, they have similar characteristics. She had this heart problem, which is this bicuspid aortic valve and coarctation of aorta, and he had the pulmonary stenosis, and both of them, they try to maintain the streak in the Snapchat. That's why she will be having a streaky ovaries. Okay, so itna yaad rakhna. I guess you will able to correlate what are the features of this Turner syndrome. Okay, yeah, Noonan, it is the male counterpart of Turner syndrome, which can be seen in both males and females. Okay, fine. And next about this Klinefelter syndrome. This Klinefelter syndrome, it will be having this one. Just remember this 2 to 3 features. This one of them is this gynecomastia. Gynecomastia. Okay, gynecomastia, and there will be large testes. Okay, if it is a male, so there will be small testes will be there. There will be small testes. Yeah, then the IQ will be normal in the case of Turner syndrome, and it will be associated with a thing which is known as lymphedema. So the neck, like instead of web neck, you can also tell there is a swelling here. It is known as lymphedema. Fine, lymphedema. Yeah. Yeah. In the case of Klinefelter, you will be able to see this bare bodies. Okay, fine. Yeah. Next, if you are able to see this Edward syndrome, see, remember Edward, it is the 18. Edward 18. Okay, in everywhere in Edward, it is everything is elongated. So elongated hands. If the hands are elongated, then we cannot hold it inside. So what will happen? There will be overlapping of fingers. Overlapping of fingers. Fine. And then the child will be having this rocker bottom foot and elongated kidneys, which is this horseshoe kidneys. Fine. Yeah, what is the question, Puneet? Fine. Next, if you are able to see about this next one, where there is a presence of this R central defects, is like cleft palate and cleft lip, and along with this, there is this R defects, which is VSD, which is mostly seen in both VS means Patau syndrome and Edward syndrome. Fine, Patau syndrome and Edward syndrome, and here there will be more dactyly, which is known as polydactyly. Fine. Like in Klinefelter, it will be mostly hypogonadism, doctor. Like it is the hypogonadism. Okay, hypogonadism at the level of testis means testis will be small. Okay, whereas if we see about this here at the level of pituitary, there will be more action. So this is what it is, this hypergonadotrophic hypogonadism. So hypogonadism will be there, but it is because the problem is at the level of testis, but whereas the pituitary function will be normal. Okay, just remember. Whereas in the case of Kallmann syndrome, it is hypogonadotrophic hypogonadism, along with this anosmia, remember. Fine. And about Patau syndrome, Patau, so it is the trisomy of 13, and they will be having this P, all these P features, cleft lip, cleft palate, and we saw one more thing, which is the coloboma, which is this colobosoma. Yeah, there will be low testosterone, like usually if it is low testosterone, then the FSS in LH will be more. Okay, remember. Yeah. Kallmann will be also hypo, along with this anosmia, means loss of smell. Okay, and this 13 will be this Patau syndrome. Fine. And about next important part about the CNS of this pediatrics one, it is the febrile seizures. Okay, if you see this febrile seizures, it will occur from around 6 months to 6 years of child. And what are the what are the risk factors can be associated? And if there is any case of this febrile seizures, it will be managed. It will be having this kind of features where it will be managed with this rectal diaphragm. So if there is any active seizures, हमें पहले एयरवे देखना है, फिर उसके बाद क्या करना है कि बेंजोडाइज़पिन देना है. मोस्टली हमें पेरेक्टल बेंजोडाइज़पिन हम देंगे, ठीक है, बेंजोडाइज़पिन देंगे, and mostly will start intervention if it is more than 5 minutes, ठीक है. And for intermittent prophylaxis के लिए हम oral clobazam देंगे, fine, oral clobazam देंगे. And what are the risk factors for this recurrence of seizures? Like in few cases, this febrile seizures may occur again and again. What are the risk factors? If the age is less than 1, we told it is around 6 months to 6 years it may occur. But if the age is around 6 months only, if it is less than 1 year, then there is a major risk factor. And if the duration of fever is less than 24 hours, if it is more than, it is fine. If it is less, it is not fine. Then the fever is around maintaining the range of 38 to 39 degrees Celsius. So it is one of the major risk factors. The minor include there might be a presence of family history and family history of other seizures like epilepsy, or if there is any complex febrile seizures, or if the baby was left in a daycare with there is less caring, okay, and if there is a male gender, and if there is increased sodium at the type of presentation. So all of these features, they can be a minor factor for this recurrences, whereas major one, it is the age less than 1 year and the temperature between 38 to 39 and the duration of fever, it is less than 24 hours. So these are the few risk factors you should know of, fine. And next about this epileptic seizures. Okay, epileptic seizures में हमें पता है neonates में the most common one, it is the subdued seizures, and the most common cause of this neonatal seizures क्या है? It is the hypoxic ischemic encephalopathy. It is this hypoxic ischemic encephalopathy. याद रखना. Next, what is the drug of choice of this neonatal seizures? इसके लिए हम देंगे phenobarbital. ठीक है, तो most common one it is a subdued seizures, or most common cause क्या हो सकता है? It is hypoxic ischemic encephalopathy. And next, if you see, what is the drug of choice? It is the phenobarbital. Yeah, fine. Next, if you see a 8 years old female who is presented with features of this vacant look, ठीक है, जैसे तुम गए थे, means when you were sitting in a pediatric OPD and when the baby came and it starts giving you this vacant look, this kind of silent and vacant look, okay, and along with this post-ictal confusion, it will be typically seen in a case of absent seizures, okay, absent seizures, yeah, fine. And here you will be able to see this EEG finding of 3 hertz spike. You will be able to see this EEG finding of 3 hertz spike, okay, and this is the typical features of this absent seizures, okay, absent seizures. And we know in a case of absent seizures, अगर बच्चे हैं तो we'll give this ethosuximide, or we can give in later part, or if it is in adults, we'll give this valproate. So remember this absent seizures, this vacant look, and it can predispose, or we can create the seizures by telling the patient to hyperventilate. You give this fan, like in childhood you will be having this small fan kind of thing, right? Like when you show with the ear, like air, it will be running. So you will tell the patient to, will tell them to blow the fan. So when the patient is hyperventilating, then this episode will occur. So mostly it will be described in the questions, and EEG there will be showing this 3 head spike pattern, 3 head spike pattern, and it is seen in a case of absent seizures. और उसको treat करने के लिए हम क्या देंगे? ethosuximide देंगे, ठीक है? Then if there is a male infant who is presenting with these features of delayed milestones and jerks involving the head, neck, like a salam seizure, so ECG is showing this hips arrhythmia, it will be seen in a case of, yeah, good, it is in a case of West syndrome, okay, or which is this infantile spasm, or infantile spasm में हम क्या देंगे? Will give this high dose of ACTH, will give this high dose of ACTH. अगर if infantile lesion, if it is associated with this tuberous sclerosis, अगर tuberous sclerosis है तो हम क्या देंगे? TB देंगे. So remember, it is the tuberous sclerosis will give TB, that is this vigabatrin. It is this vigabatrin will give in a case of infantile spasm with, in a case of tuberous sclerosis. Okay? Then you say a 13-year-old female with complaints of jerks in the hands leading to frequent fall of objects, means it is causing this myotonic jerks. So if you are able to see this type of myotonic jerk, and along with this EEG, there is a presence of this polyspike pattern. There is a presence of this polyspike pattern. It is be suggestive of juvenile myoclonic epilepsy. It will be suggestive of juvenile myoclonic epilepsy. It is be suggestive of juvenile myoclonic epilepsy. Fine. Then what is the treatment for this juvenile myoclonic epilepsy? It is the treatment versus this lamotrigine or levetiracetam. It is this lamotrigine or levetiracetam. Okay. Let me ask you a question from the medicine and pharmacology part. You say a female who is willing to conceive and she is on valproate. Up, what you will do? What you will do now? Will you tell, yeah, no problem, just take this valproate, or will you change them into this levetiracetam or lamotrigine especially? What you will do, guys? Yeah, will change. If the female, she is having this idea, मुझे pregnant होना है, तब हम क्या करोगे? Then you will change into lamotrigine. Then if there is already वो मन बना के pregnant भी होकर आई है तेरे पास, तो तुम्हें क्या करना है? तो आपको क्या करना होगा? आपको करना है, ठीक है, आप तो phenylketonuria कर रहे हैं, कोई दिक्कत नहीं है, valproate ले रहे हैं, just take up more doses of folic acid. ठीक है, बस आप इतना करो, don't change the tablet. ठीक है, बस इतना करना. Yeah. Then about this few conditions, like if there is any seizures, ongoing seizures चल रहा है, तो हमें पहले करना है, पहले हमें एयरवे चेक करना है. मतलब एयरवे, मतलब we should, like if the patient is going, then we should move them into this left side, okay, left lateral position in the left side. Then once we secure the airway, we'll check for this breathing and circulation. If everything is fine, हमें IV access करना है. IV करने के बाद we need to send for this blood investigations, क्योंकि sometimes this electrolyte imbalance can cause this. फिर उसके बाद हमें पहले benzodiazepines देना है. For example, if there is lorazepam से शुरू कर सकते हैं या मिडाज से शुरू करते हैं, but midazolam will avoid in a case of liver failure and things. Fine. Second line, हम child को हमने एक benzodiazepine दी है, फिर भी then the seizure is not stopping, then we'll give this IV phenytoin. Fine. Whereas if it is adults, we'll go for this levetiracetam. अगर ये भी देने के बाद भी, means if after giving this phenytoin or levetiracetam, if it is still occurring, then we'll go for the valproate. ठीक है, याद रखो. So this is the thing you need to remember about this management of the seizures and this epilepsy part. Then you need to see about this short stature. Yeah, if there is no availability of, that's what, like if there is no levetiracetam, lamotrigine available नहीं है, तब आप phenytoin दे सकते हैं, means like valproate दे सकते हैं, ठीक है ना? So that is the one. Yeah. Then about this short stature, there are two types of short stature. Means there will be this upper segment and lower segment ratio. अगर दोनों maintained है तो उसको बोलेंगे proportionate stature. Okay. upper segment, lower segment. Okay, and if it is not, one side is big, one is small, it is known as disproportionate short seizure. तो क्या क्या हो सकता है? One is this abnormal short limbs. क्या है? For example, in the case of achondroplasia, there will be this trident hand will be there, and there will be this champion glass pelvis. Okay, trident hand and champion glass pelvis in the case of achondroplasia. Or in the case of mucopolysaccharidosis, हमें पता है mucopolysaccharidosis, what is the classical presentation? There will be this coarse spaces will be there, and there will be corneal clouding will be there. Okay, corneal clouding will be there, and on bones they will be having this deformity which is known as Erlenmeyer class deformities. तो थोड़ा बहुत उसको ये करना, मतलब mainly remember about the facial features like our Hurler syndrome. These are this mucopolysaccharidosis. Fine. फिर उसके बाद this will come to this proportion. कुछ टाइम पे ये नॉर्मल हो सकता है. फॉर एग्जाम्पल फैमिली में नॉर्मल है तो द चाइल्ड ऑब्वियसली विल बी हैविंग normal and it will be short in nature, so it is obviously normal one. Whereas there will be a constitutional delay in short stature. मतलब कुछ टाइम तक the बच्चा will be small, like okay, the child will be small. After some time, during this adolescent age, the बच्चा will be having this peak growth. So it is what it is, this constitutional delay. ठीक है. And next about the pathological. कुछ prenatal cause हो सकते हैं. For example, some of the drugs which causes intrauterine growth restrictions, okay, or any infections की वजह से, okay, वो हम पढ़ेंगे. और नहीं तो any other disorders, for example, in the case of Turner syndrome, the child will be small, will be having the short stature. So all of these things will lead to this proportion short stature. Whereas पैदा होने के बाद क्या हो सकता है? शायद उनको खाना कम मिला हो, उसको बोलते हैं कि अंडर न्यूट्रिशन, या नहीं तो क्रोनिक इलनेस. फॉर एग्जाम्पल इन द केस ऑफ कार्डियोवास्कुलर डिसीज, या नहीं तो फिर इन द केस ऑफ हार्ट फेलियर, और इन द केस ऑफ किडनी डिसीज और एनी अदर डिसीजेस, इट मे लीड टू दिस शॉर्ट स्टेचर. ठीक है. एंड देयर इज दिस endocrine causes like especially this growth hormone and hypothyroidism. ये भी एक करा सकता है. Okay, ये भी एक करा सकता है. But most common one you should know, it is this, the proportionate short stature. ये क्या है? It is what it is, familial short stature. Means not familial. It is this constitutional delay in development. Constitutional delay in development or constitutional delay in development में at the end of the day, finally the baby will be having this normal stature. ठीक है. ये याद रखो, the baby will be having this normal stature. ठीक है. Then we'll come on to this STAM का definitions. Okay, stunting कब बोलेंगे? stunting मतलब short रहना. ठीक है. तो there is a low height for age. wasting मतलब weight को लेंगे तो low weight for height. तो low weight for height in the case of wasting. Whereas underweight कब बोलेंगे? there is a low weight for age. Whereas this low weight for age. Fine. And about interpretation, अगर stunting है means if there is height decrease है तो it is because of this chronic malnutrition. Whereas in wasting means if there is relation to the weight, it will be what? It will be mostly acute in nature. Okay, acute in nature. So wasting it will be what? It is acute malnutrition. Whereas if it is weight, it is acute. Whereas height, ठीक है ना? Height बढ़ने के लिए बहुत देर लगता है, लेकिन 3 महीने में वेट बढ़ जाएगा, 3 महीने में वेट कम हो जाएगा. फॉर एग्जाम्पल आपका तो अभी तो आपका वेट बढ़ रहा होगा because of this depression stress. ऐसे आप इंटर्नशिप में जाओगे, then your weight will start reducing. So but your height is not like that. Your height will be almost similar. तो height के लिए time लगता है. तो remember the height will be manifested as a, or the height changes are manifested as a chronic malnutrition process. तो इसीलिए stunting में will count for this height for age, which is this chronic malnutrition. Whereas in the case of wasting, we'll use this weight part, which is this weight for height, which is seen in the case of acute malnutrition. ठीक है. Whereas underweight कब बोलेंगे? Which when there is a weight for age is less. ठीक है. Which is the acute and chronic malnutrition. ठीक है. या वही मतलब ड्यूरिंग दिस प्रिपरेशन पार्ट टेंशन में थोड़ा बहुत ज्यादा ही खाना खा लेते हैं, थोड़ा बहुत ज्यादा ही सो लेते हैं. ठीक है. कोई ना अभी 30-40 दिन का, फिर उसके बाद तो मन ही नहीं करेगा खाने का. ठीक है. देन अबाउट व्हाट आर द डेफिनेशंस यू नीड टू नो अबाउट दिस SAM. या अबाउट दिस SAM you need to know the weight for height if it is less than 3 standard deviation, or if there is any features of severe wasting, or this mid-arm circumference which you measure using this Shaky state if it is less than 11.5 centimeter, or if there is presence of edema, if there is presence of edema of the bilateral field. ठीक है. तो इतने सारे definitions आपको याद रखना है about this severe acute malnutrition. Fine. And in next questions they will ask you what are the complications can be associated with this severe acute malnutrition. So remember it is the hypoglycemia, hypothermia, infections हो सकता है, नहीं तो like it will be known as shield chest. ठीक है. shield chest. Okay. Remember about this shield. S for sugar. ठीक है. sugar. So H for hypothermia will be there. I for infections will be there. E for electrolyte imbalance will be there. Okay. shield. Okay. C for electrolyte imbalance will be there, and D for dehydration will be there. So all of these features will be seen as a complication of this SAM. Okay, seen as a complications of the SAM, and all of the following should be taken care during its treatment or treatment modality. Okay, so remember, and the fluid of choice will give is oral with 5% dextrose. Okay, once hospital में आ गए तो they should get discharged, but when you will tell the patient is okay for discharge, once you discharge them they will gain their weight. तो तब आप कब बोलोगे कि if the edema component has improved, fine, and if there is an adequate weight gain per gram, and the child should get the food orally. It is not TPN, the child should eat orally and the appetite should become normal, and the caretaker should be confident enough to handle the child. Okay, ऐसे नहीं कि मतलब they think like still कुछ नहीं होगा, then obviously कुछ नहीं होगा. लेकिन when you start thinking yeah मुझसे हो सकता है, FMG निकाल सकते हैं, ठीक है ना, then the same with the child, like the mother will tell हाँ मेरी बच्ची है तो I will take care of this. So then when the confidence come, then you need to discharge them. Okay, confidence along with these features. Only ऐसे नहीं confidence हो गया बच्चे सही हो जाएगा, बिल्कुल नहीं, ठीक है, confidence भी होना चाहिए, उसके साथ साथ काम भी होना चाहिए. So you should have confidence as well as you need to read the notes, you need to do questions, then only you will be able to get or you will come out with flying colors. ठीक है, ऐसे नहीं है नोट्स सारे खरीद के रखे, सारे प्रिंट करा के रखे, आंख बंद कर लेंगे, एग्जाम में जाएंगे और पास हो जाएंगे, ऐसे बिल्कुल और कभी नहीं होता. मेहनत करने वाले को बिल्कुल अच्छा रास्ता और सही रास्ता मिलेगा. So just put your efforts in the right directions and go ahead with the right part, you will get the right thing for sure. ठीक है, बस इतना ही. Yeah, it was a PVQ. Yeah, good Dr. Anar. Yeah, nice notice. Fine. Next, about two things you need to know about this kwashiorkor and marasmus. If you see about this kwashiorkor, see, if this child is sitting like this, here its belly will be like this. So remember this K, it will be having this belly. Okay. So it is what? It will be having the edema present. Okay. This belly edema will be present in a case of kwashiorkor. Okay. So kwashiorkor, it is mainly due to this protein malnutrition. अगर protein malnutrition की वजह से the child will be having the less appetite होगा. Okay. And child will be floppy. अगर आप उसको खाना भी दोगे ना वो नहीं खाएगा. Okay. Then, if it is a case of marasmus, it will be a vigorous baby and skinny baby. It is because of this energy. It is because of this both energy and protein malnutrition. Remember, okay? And they will ask these two signs. Where you will see this flaky pain dermatitis. Okay? हाँ वही है, PVQ का ही है. ठीक है. So if you see, it is this flaky pain dermatitis. You will see in a case of kwashiorkor. ठीक है. And next, this flaxen also will be seen in the case of kwashiorkor. Okay. So if you see this kwashiorkor part, I told you it will be having this edema present and pedal edema because decreased protein है. So protein decrease है तो क्या होगा? If there is decrease in protein, then there will be decrease in osmotic pressure. Osmotic pressure decrease होगा तो edema होगा. So there will be a presence of edema. Okay, there will be presence of edema. The child will be lethargic. आप जितना भी खाना खिलाओ बेटू बेटा बेटी, then it won't accept it. Whereas marasmus, आप बस खाना दिखा दो वो खा लेगा. ठीक है. So there will be voracious appetite and along with this the child will be active in nature. बस इतना याद रखो. Yeah. या SAM में हम reosmol दे सकते हैं. Yeah, good. We can give this rehydrated osmolar solutions in a case of SAM. Yeah, that's good. Fine. Next we'll see about this MCD, minimal changes. We told MCD, it is the most common cause of nephrotic syndrome in children. Okay. Whereas PSG, it is the most common cause of nephritic syndrome in children. Okay. Then minimal changes में you know it is a nephrotic syndrome, so protein loss होगा, there will be a presence of edema. Okay. So there will be a presence of massive proteinuria, तो blood में protein का level कम होगा. So this and also this leads to this concurrent increase of this hyperlipidemia. और हमें पता है लाइट माइक्रोस्कोप में हमें कुछ नहीं मिलने वाला है, तो इसीलिए हम जैसे when you do this electron microscopy, you will see this effacement of podocytes. ठीक है, podocytes. ठीक है. Next about this part, which is this post-streptococcal glomerulonephritis. ठीक है, there will be a history of sore throat, and after 14 days of sore throat, the child is presented with this cola colored urine, which is the hematuria. और हमें पता है in a case of nephritic syndrome, huha, hematuria, oliguria, hypertension, and azotemia. तो these are the features seen in a case of nephritic syndrome. और वही ये PSG ने भी manifest करेगा, and PSG ने भी वही manifest करेगा. So there will be presence of this hematuria, which is this cola color urine, and some level of proteinuria will be there, and hypertension, and ASO levels also will be high, and it is because of this पेप्टोस्पायरोजेनस, सो देयर विल बी एंटी डीएनएस एंटीबॉडी लेवल्स विल बी मोर। ठीक है, बस आपको इतना याद रखना है, और पीएसजीएन वो अपने आप सही हो जाएगा, आपको कुछ नहीं करना है, आपको घर बैठे बस देखना है। ठीक है, बस इतना काम करो। ठीक है, नेक्स्ट अबाउट दिस डायरिया कंपोनेंट और दिस डिहाइड्रेशन। ठीक है, सी if there are three levels of dehydration: no dehydration, some dehydration, and severe dehydration. ठीक है, in a case of no dehydration, there will be means the child will be having the episodes of vomiting or diarrhea. लेकिन क्या हुआ, means in a case along with this, there if you see this signs, I0 will be sunken, and if you see this tongue, it will be wet with the salivations, it will be wet, and when you do the skin pinch, it will go normally. So सब कुछ नॉर्मल है, तब क्या होगा, it is a no dehydration part. तब हम क्या करेंगे, कुछ नहीं बेटा, बस ORS पी लो। ठीक है, हाँ जूस पी लो नहीं, it is ORS पी लो। ठीक है, जूस पी लो मौसमी का नहीं, it is ORS पी लो। ठीक है, just okay, right. And next about this some dehydration part. If you see about this some dehydration part, then if you able to see here, the child will be restless. Yeah, the child will be restless or irritable, and it will be having this sunken eyes, and it will be, and जैसे आप उसका मौसमी का जूस साइड में, when you will give this ORS to this child, then it will drink this water very eagerly. ठीक है, so in a case of some dehydration, the child will be thirsty and it will drink eagerly. और जैसे आप स्किन का टेस्ट करोगे, then it will be what, then it will be decrease, but not to a very much level, it will just glow, it will go very slowly. Okay, it will go slowly, it will not go very slowly, and there will be small sunken eyelids, and the child, main differentiate picture क्या है, the child will be thirsty, मतलब उसको प्यास लगेगा। ठीक है, जैसे आपको पानी पिलाओगे, वो अब it will start drinking the water. ठीक है, whereas in a case of severe dehydration में, yeah, in a case of severe dehydration में, the other signs will manifest. Thus the fontanelles will be sunken, the child will be what, it will be very much lethargic and unconscious, the eyes will be sunken हो जाएगा। ठीक है, and the child will not able to drink water. और जैसे आप स्किन पिंच करके छोड़ोगे, यूजुअली इट विल गो नॉर्मली, एंड इट विल टेक मोर देन 2 seconds टू गो इटसेल्फ। ठीक है, तो वो बहुत स्लोली जाएगा, वो स्किन का टर्गर चला जाएगा। ओके, सो दिस आर द थिंग्स यू विल सी इन अ केस ऑफ सीवियर डिहाइड्रेशन। ठीक है, तो व्हाट इज द मैनेजमेंट, आप क्या क्या करोगे। ठीक है, इफ यू सी इन अ केस ऑफ नो डिहाइड्रेशन, बस कोई पानी पी रहा है, बस उसको पीने दो। ठीक है, यू विल गिव व्हाट, यू विल गिव जस्ट ORS। In the case of some, we also give ORS, but level में आपको बताता हूँ कैसे क्या करना है करके, और उनको घर भेज सकते हैं। ठीक है, घर भेज सकते हैं। ठीक है, देखो आपका बेटा का थोड़ा बहुत डिहाइड्रेशन तो है ही, आप ORS पिलाओ। अगर आपको जो भी डेंजर सेंस, अगर बच्चे नहीं खा रहा है, नहीं पी रहा है, सीजर्स ऐसे कुछ आ रहा है, तब आप लेके आना। मीन्स इफ देयर इज एनी डेवलपमेंट ऑफ any of the danger signs, like if the child is not feeding well, if the child is becoming unconscious, or if it is becoming very much restless, तब आपको लेके आना है। ओके everyone. So then, whereas if it is in a case of severe dehydration, you should refer to this pediatric available hospitality, and you should manage them. Okay, fine. And until unless it is lab confirmed, you won't give antibiotics. Okay, so we'll see how this dehydration part can be done. See, in the case of plan A, it is no dehydration, कुछ भी नहीं है। ठीक है, कुछ भी नहीं है। ठीक है, लेकिन वो माँ कभी मानेगी बिल्कुल नहीं। ठीक है ना, so the mother won't accept it. So what will give, there is a no dehydration part, but because of the vomiting, there will be a fluids component will be lost. So we need to replace the fluids with the ORS. Okay, we'll give 100 to 200 ml of ORS. ORS which is, we will tell them like 1 liter का bottle लो, और उसमें ORS का sachet, like just mix it, and whenever the baby asks, or whenever the baby goes for a loose stools, give them this ORS ka water. Okay, ORS ka water, fine. So this is one. Okay, this is to replace, matlab ulti ki, dobara pi, dobara ulti ki. So this will be the phenomena. Then in a case of some dehydration, we'll give this plan B. Okay, what we'll do here also, we'll prefer giving this ORS, but with a more advanced, like with usual one, with ongoing loss we'll give, and along with this we need to give this drugs. For example, we need to give this fluids as 75 ml per kg. Okay, in first 4 hours we need to give 75 ml per kg for this child. Okay, because there will be more loss, and we need to replace this ongoing loss, because the child will be having a level of some dehydration. Okay, in a case of severe dehydration, mostly मैंने बोला the child will be lethargic, so the child won't able to drink. तो वी नीड टू गिव ओनली IV, सो वी शुड स्टार्ट IV फ्लूइड्स इन केस ऑफ प्लान C, ठीक है। प्लान B में द बच्चा इज ड्रिंकिंग वाटर, सो विल यूजुअली विल गो विद ORS, ठीक है। तो पर केजी के हिसाब से 75 ml करके कैलकुलेट करेंगे, एंड इफ नॉट देन विल गो फॉर IV, whereas in the case of plant C, straight away will start with IV fluids and mostly will give the same, bring a 5% dextrose with RL, okay, 5% dextrose with RL more means more preferred than compared to normal saline, ठीक है। फिर उसके बाद उसका मेंटेनेंस डोज देंगे, ठीक है। उसके पहले हम क्या करेंगे, उसका जो भी डिहाइड्रेशन कंपोनेंट को करेक्ट करने के लिए विल यूज दिस फॉर्मूला, ठीक है। तो वी नीड टू गिव 100 ml per kg, ठीक है। तो उसमें if the child age of the child is less than 1 year, then what will give will split this 100 ml into 30 ml per kg and 70 ml per kg, ठीक है। ये 30 ml को हमें पहले 1 घंटे में देना है, if the child is less than 1 year will give within 1 hour, 1 hour less than 1 year 1 hour, and rest the 70 ml of kg, ठीक है। For example, if the child is what, if the child is around, मान लो कि if the child is 4 kilogram, then it is 4 liters, like 4 kilograms, then it is 400 ml. So 400 ml में see if it is a case of 400 ml, then per 30 kilogram, 4 3 are 12, like around 120 ml will give in 1 hour, then rest will give in like next 5 hours, ठीक है। If it is more than 1 year, then will give total in within 3 hours only. So first 30 minutes में हम around 30 ml per kg देंगे, फिर उसके बाद हम 70 ml per kg करके इसको स्प्लिट करके देंगे, ओके फाइन। एंड एडिशनली व्हाट विल डू, will give this dose of zinc, ठीक है। हमें पता है if there is diarrhea होता है, then this superficial epithelium, ठीक है, this superficial epithelium it will erodes of this and comes off. So ये epithelial को अच्छा करना है, मतलब this epithelium should regrow. So for this regrowth will give zinc as a supplement, and zinc supplement if the child is between 2 to 6 months of age, फिर उसको हम 10 mg per kg per day देंगे। अगर if it is more than 6 months, फिर हम 20 mg per day के हिसाब से देंगे, ठीक है। बस इतना ही। If it less than 6 months, then it is what? Then it is 10 mg per day, and if it is more than 6 months, it is 20 milligram per day, ठीक है। या and finally, ठीक है, we need to give means these are this for this dehydration component। फिर उसके बाद उसको तो डेली डोसेस ऑफ यूजुअल फ्लूइड्स भी चाहिए ना, तो उसको कैलकुलेट करने के लिए हम ये हॉलिडे सिगर फॉर्मूला यूज करेंगे। फॉर एग्जांपल, इफ द बेबी वेट इज 5 kilogram, then we'll use just like 100 ml per kg, so it is 500 ml. Whereas if it is more than, if it is 0 to 10 kilogram, then we'll use 100 ml per kg. अगर जो भी आपका उसके बाद अगर if it is 11th kilogram to this 90 to 20th kilogram, तो हम extra 50 ml. For example, if the child weight is 10 kilogram, तो 1 लीटर देंगे, ठीक है। फिर उसके बाद if it is more 1, we'll multiply is with 50, ओके। तो क्या है, तो it is 1050 ml, ठीक है। एंड इफ द चाइल्ड इज if it is more than 20 किलोग्राम, फिर उसके बाकी 1-1 किलो के लिए हम 20-20 ml का वाटर देंगे। 20-20 ml का 20-20 ml will increase if it is after more than 20. So see, if it is within 0 to 10 kilogram, will give 100 ml per kg. After each 1 kilogram of weight, then we'll give add 50 ml per kg, and if it is more than 20 kilogram, then we'll add plus 20 ml per kilogram, guys, ठीक है। तो it is the formula for this maintenance fluid calculation, ठीक है। Then we'll come to a few extra aids in the pediatric part. Extra aids में क्या क्या देखेंगे, if you see there are few congenital infections which can result into this changes into the child, ठीक है। क्या क्या हो सकता है, we'll call them as torch infections। टॉक्सोप्लाज्मोसिस में हमें हाइड्रोसेफलस मिलेगा, कोरिया रेटिनाइटिस मिलेगा, और पैरेन्काइमल कैल्सिफिकेशन। सी most of them they will be having this CNS calcifications, लेकिन आपको differentiate करना होगा this toxoplasmosis, okay, toxoplasmosis, then it will be what, then it will be having this parenchymal calcifications, ठीक है। about 15 kg, see if the child is 15 kg, then treat first 10 kg, then 5 kg। तो first 10 kg के लिए हम 100 ml के हिसाब से देंगे, तो 10 into 100 1000 ml, then next 5 kg के लिए 50 के हिसाब से देंगे, तो it is 250 ml, ठीक है। so this will be what, this will be 1250 ml, ठीक है। 1250 ml हम देंगे, ठीक है। you got it right, I guess, okay, for this day, right? Then in a case of Zika virus infections, you know, like they will tell the history that they are living in Kerala, or mostly they are living in where, in a case of Malaysia, where there is a availability of this palm sap, ठीक है ना। From Kerala there will be kallu will be available, where if you are able to drink this kallu or this like from this palm sap or this coconut sap, they will be secreting this liquids which is being contaminated with the bats. It will lead to this feature which is known as what? Microcephaly. Okay, microcephaly. I will tell you what is Brown-Forman disease. Wait till dermatology. Fine, just wait. Okay, then if you see about this Zika disease, you will be able to see there is a presence of contractions also present, and there will be calcification at the level of grey matter and white matter junction. It is simple, nothing. It is the tuberous sclerosis Brown-Forman means. Okay, don't worry. Then varicella, there will be presence of cicatricial scarring, and along with this there will be features of limb hypoplasia. Limb will be hypoplastic in a case of varicella, like the simple chickenpox one. Okay. Then for this, if them is susceptible, then if it is being infected just 5 days before delivery or 2 days after delivery, then we need to give varicella immunoglobulin. Yeah, that is HHV3. Good guys. Then about HSV, it will be having mostly, it will cause this skin infection sometimes, or mostly it will cause encephalitis in the neonates. Fine. And parvovirus B19, हमें पता है it will cause non-human fetalis hydrops. Okay, non-human hydrops fetalis. Then it can cause this aplasia as well. Okay, pure red cell aplasia. याद रखो. Okay. Then about next syndrome, which is this congenital rubella syndrome, it will be associated with this cardiac defect, and there will be presence of this deafness. Okay, and there is a presence of cataract. So your main senses, like your feelings on the heart, it will be affected in the case of rubella. Okay, then your eyes, means you used to see the ruby, so your eyes will be affected, and you will able to hear the voice of ruby. So all of this thing will be affected. So there will be a deafness, cataract, and and there will be PDA. प्यार में दिल प्यार के बाद there will be andha, bera, and dil tuta. Okay, the three things. Okay, so there will be features of this eye and ear and the heart one. Okay, and then eye also you will able to see this salt pepper retinopathy, and in skin you will able to see this blueberry muffin rash. Okay, kind of muffins, there will be this small blue color का rash होता है. ठीक है, blueberry जानते हैं ना, तो वैसे बराबर. ठीक है. Then about the CMV, there will be presence of this CMV small. Okay, there will be CMV small wala. So small head will be there. It is known as microcephaly, and it is associated with this periventricular calcification. It will be associated with this periventricular calcification. Okay, yaad rakho. So these are the things. Then it is the CMV. Then just remember, this is all about this pediatric part. Means for everything in your life. Like it is just take for this FMGE examination or everything in the life. Like isonic means you think like yaar nahi hoga yaar, uska nahi hua. Don't compare everything to the others, because tum alag ho, you are unique. Okay, so as you are unique, you need to work on yourself, and you know only your potential. So don't think of others and don't compare yourself with others. ठीक है, और ऐसे नहीं सोचना ठीक है यार कल से रिवीजन चालू करेंगे, कल से क्वेश्चन लगाना चालू करेंगे. I will start from tomorrow. नाले इल्रंदु क्वेश्चन पढ़ला. So when this tomorrow, it's never come. Okay, so just try to start as early as possible and start today. Okay, so just have a start. You will be great for sure, and you will pass this examination for sure. Okay, have this mindset. फिर उसके बाद आगे बढ़ते हैं next subject.